Right, a very good morning, good afternoon, and good evening, ladies and gents, and welcome from the ISHA operating room in Chicago, and Brian in US and me in the UK. So the aim of this series is obviously to show or spotlight operations, i.e. hip arthroscopy and open hip preservation surgery through this series. And we've got the master at work in Chicago at the American Hip Institute, Ben Domb, and we'll be quizzing him along as we go along, as he operates with Brian and myself throughout. So we've got 90 minutes of show time with Ben Domb. Ben, over to you. Tell us what you're up to.
Great, thank you. And Brian Lee, can you spotlight the outside camera again for a second? Thank you. Good morning, everybody. Dr. Benjamin Domb here at the American Hip Institute in Chicago. It's a pleasure to be with all of you, and I hope all of this wonderful technology is facilitating you seeing everything perfectly clearly. I look forward to seeing all of you in Africa, or many of you, during our ISHA annual meeting, which is the flagship event of ISHA. That's in Cape Town next week. So we all look forward very much to that. I did also want to represent, as chair of the education committee for ISHA, the upcoming education program for the year, which will consist of several live surgeries such as this one today, as well as several webinars, which will be organized by Dr. Brian Giordano, who is also with us moderating this live surgery today and can say a few words about the webinars at the conclusion. Today's live surgery is presented with the assistance of Proximie. ISHA has formed a partnership with Proximie, which provides outstanding technology for this live surgical feed, as I think you'll see during the demonstration today. And I'd like to thank Caroline McKenzie from ISHA and Proximie, all the people who have worked so hard to make all of the technology happen today. Also, thanks to our moderators, again, Dr. Zvika Skanduja and Brian Giordano, who are with us in surgery. So to start off with, I'll begin by talking about this particular patient. And Brian Lee, if you could spotlight the x-rays now, please. So on the x-rays, you'll see four views here: an AP pelvis, a false profile, upright AP pelvis, and a bilateral Domb view. This young man is an elite level hockey player. He's an excellent hockey player. And like many hockey players, he has developed cam morphologies over the course of his hockey career. He has them in both hips, the right perhaps a little worse than the left. If we look on the bilateral Domb view, that's quite evident. In terms of his acetabular morphology, his lateral center edge angle is 29 degrees. He does not have any particular retroversion of the acetabulum, and he has perhaps just a little bit of calcification anteriorly on the false profile on the anterior rim. The joint spaces appear intact, as you would expect in a young elite level hockey player. So the thing that jumps out here is the cam morphology. And again, this is sort of a textbook hockey FAI type of case. So I know that not all countries who are on the line have a large representation of hockey in their countries, but we certainly do in North America. And hockey seems to breed this formation of cam morphology. If we could flash to the CT scan view for a second, Brian Lee, if we could flash to the CT, spotlight the CT. Thanks. Just to see this in a little more detail, we can see on the CT scan the morphology, and you can see in blue on the left hand side of the screen the area that the software picks out as aspherical and hence cam morphology. We also do take a number of measurements with the CT scan. I won't bore you with all of these measurements, but we confirm the center edge angle, the acetabular version, the tonus angle, acetabular coverage, which is an interesting number. That's the percent coverage of the superior hemisphere. That's 49%. The alpha angle, and the femoral torsion, which is a really helpful number to have. Femoral torsion here is 1 degree. That's less than average. It's not retroverted, but it's almost neutral version, as opposed to an average being about 15 degrees anaversion. So that's another factor that predisposes this elite hockey player to impingement, to femoral acetabular impingement. I have already done the access to conserve a little bit of time, but I'm going to go back through what I did just briefly here. You'll see on these fluoro x-rays, this is the first x-ray where we had vented the joint as we applied traction. The venting of the joint allows for less force to be used to achieve this degree of traction. And as we approach the joint with the spinal needle, you'll notice that the spinal needle is not pointed toward the center of the error arthrogram. It's pointed toward the most inferior part of the error arthrogram. This gives us the most reliable way to avoid penetration of the labrum. And the technique you'll see here is one we've published on quite some time ago as a way to minimize labral penetration rate and keep it ideally under 1%. So the approach angle of the spinal needle is a little bit distal to proximal, and that enables us to have a favorable angle to avoid the femoral head throughout the course of the procedure. Gene, next x-ray, please. On the next x-ray, sorry, question. Yes, Brian.
Ben, could we stop you there and just discuss the preoperative radiographs and the CT scan before you jump into the operative?
Oh, yeah, absolutely. Absolutely. Let's, so I'll, Gene, back up, and Brian Lee, can you spotlight the x-rays again, please?
If we actually go on to the CT image, I've got a couple of questions there.
Sure. Let's spotlight the fluoro then again, and I'll bring that back up.
The next slide and the CT. Yeah, perfect.
Can you spotlight the fluoro, Brian Lee? Thanks.
Yeah. So when you're saying he's got a femoral version of 1 degree, how do you make a decision whether a hip arthroscopy is probably the right procedure for him, or a femoral osteotomy?
Yeah, great question.
When do you consider a femoral osteotomy over a hip arthroscopy in these individuals?
Right. Excellent question. So at the extremes of femoral version, an extremely anteverted femur or an extremely retroverted femur, a rotational femoral osteotomy is an excellent procedure. The way we perform that here is with an intramedullary nail with a percutaneous osteotomy about 5 centimeters below the level of lesser trochanter. So it's a purely percutaneous procedure, and it's purely rotational. It therefore really does not lengthen their recovery at all because we can let them bear weight as tolerated as soon as we want on the femoral nail. So the osteotomy doesn't lengthen their recovery in any way. In terms of criteria to do it, we've generally considered a femoral anteversion of greater than 30 degrees on the one end, on the anteverted end, or of less than minus 10 degrees on the retroverted end. And the additional criteria has been that the patient is aware that they do not like their foot progression angle. In other words, if they're excessively anteverted, they in-toe. If they are excessively retroverted, they out-toe. So in the case like this, where this patient is a little on the retroverted side of things, if he had a retroversion of less than minus 10 degrees, and I should say anteversion of less than minus 10 degrees, and had an awareness of an out-toeing foot progression angle, that would generally be our indication in a primary setting for an anteverting osteotomy. Now, in a revision setting, that changes a little bit, because in a revision setting, we are obviously trying to do something different than what was done in the first surgery. So if someone has failed an initial surgery and is back with recurrent FAI or recurrent labral tear and has version like he has, then we may give a little more consideration to an anteverting osteotomy. How about you, Vikas? How do you approach it?
No, so I don't have any evidence to actually those numbers, Ben. This is exactly what it is. I'll probably be a bit more aggressive on the retroversion side. I don't go to minus 10. If it is going to be retroverted even 2 to 3 degrees, I'll seriously be considering an osteotomy in those patients. But on the anteversion side, I agree, that's a good number to aim for. But retroversion, I've got a bit more aggression on the retroversion side.
Yeah, and Giordano, where do you sit?
Yeah, Brian, where do you sit on that?
Well, first off, Ben, I know I wanted to say a few things. I know you have traction up, and this is a case that you probably have to get started on. But, thank you very much for, having the, the courage to perform live surgery. I think anybody that's performed live surgery is, that everything that can go wrong will, and it's, fraught with pitfalls. But, we're really looking forward to your technical mastery and learning from that. And, so thank you for doing this for us. And thank you to Proximity for the platform to be able to highlight and spotlight all these technological innovations and really helping to push the needle forward on this. And I'll first just I appreciate the plug in the educational program. We're really looking forward this year to a strong webinar platform. We're going to be starting in the fall following the ISHA meeting with a webinar based on AI, some of the technologies with that, and some of the innovations that we've seen, and that's going to be exciting with a great faculty group and a bunch of programming from that point on. So very much looking forward to that, and Ben, I'm looking forward to helping to moderate this through the procedure. And I didn't want to shirk the question about my own approach to femoral version, but I did want to just highlight the fact, and I believe it looks like you're using a postless setup for your procedure. Looks like you have a couple of portals, anterolateral and sort of a traditional anterior, modified mid-anterior. I guess I would, in summary, concur with a lot of what's been said by you and Vikas. And I don't really have much divergence from the approach in terms of version. We use a lot of functional movements to determine whether somebody needs rotational osteotomy with or without arthroscopy, whether this is a primary or revision case, whether a person's tripping over their feet, or demonstrates extremes in the lack of motion. So, we use functional utilization as much as radiographic measurements. But I'll turn it back over to you, and thank you to everybody for your attendance.
Yeah, terrific, Brian. Thanks very much for being here. And fortunately, I'm actually not under traction yet, so we're fine. But I will be shortly. I'll, in the interest of preserving the anesthesia time for the patient, we'll march ahead. But we can certainly come back to the X-rays and the CT a little further at the end of the procedure if we'd like as well. So back to access, the spinal needle you see on the fluoro screen here is approaching the inferior point of the error arthrogram. And next one, please, Gene. We then flip the bevel of the spinal needle so that the beveled edge passes the femoral head. Next one, Gene. And there you see the beveled edge passing the femoral head in a very safe way. Next one. And then we can place a guide wire through the needle, and next one, and then a cannula over top of the guide wire. And as we approach the capsule, we lever away from the femoral head, and next one, so that when we enter the joint, we're levering away from the femoral head, ensuring the safety of the femoral head throughout. So with that, let's go on traction now, and we can spotlight the outer screen for a second, the camera. So just to conserve the traction time, all I've done so far is I created two portals, and we've done a capsulotomy, which I'll explain. So the two portals you're seeing here are an anterolateral portal here and a mid-anterior portal X-ray. Good. The anterolateral portal we place at 12 o'clock. We've described that technique for the 12 o'clock portal, which is referenced not off of the greater trochanter, but rather referenced off of the location of the acetabulum. So it is in the coronal plane of 12 o'clock on the acetabulum. We then create an anterior portal, and with these two portals, we can create a interportal capsulotomy. That's usually done with a beaver blade and or radiofrequency. And the interportal capsulotomy allows access to the entirety of the joint and mobility of the instruments within the joint. So let me take the probe there. We can spotlight the intra-articular view now, please, Brian Lee. Okay, so here we are inside the joint, and I'll take you through our diagnostic arthroscopy ritual. We'll begin with the ligamentum teres. Typically, we do two views of the ligamentum teres. This one is somewhat frayed. This isn't a patient in whom we would expect instability, but if it were degeneration or tearing or attenuation of the ligamentum teres is an indicator of more progressive instability. Anterosuperiorly, we see that there is chondrolabral disruption here almost throughout the anterolateral quadrant. So this entirety here, we see chondrolabral disruption, which is sort of what we'd expect given the cam morphology. You can see a wave sign as well, again, throughout, and you see that crack at the chondrolabral junction, which is caused by the shearing from the cam lesion as best we understand it. So what I'm going to do next, and I'll let the moderators jump in for a second. What I'm going to do next is begin the elevation of the capsule, and we'll remove a little bit of this synovium here, this frondular material, but we'll preserve the capsule. It's very important to preserve the capsule. That's a part of the procedure that we're describing today. And we've chosen a young and healthy elite athlete because this is sort of a bread and butter case rather than revisions or labral reconstructions or what have you. This is a bread and butter FAI case, which I think is a great way to kick off the season and the program for this year for live surgery. So I'll get on to starting to elevate the capsule, and I'll let the moderators chime in a little bit here.
So Brian,
Ben,
go ahead.
Ben, I wanted to ask, obviously a simple question, but when you start your capsulotomies, are you looking at any particular anatomic landmarks to determine how far inferior or superior posterolateral you go, or do you customize it based on the intra-articular pathology that you find?
Sorry, your question was about the portals? Right.
The extent of your capsulotomy.
The extent of the capsulotomy. I'm sorry.
And anatomic landmarks that you use.
Yeah. So the posterior extent is at 12 o'clock. And so that's basically direct lateral relative to the acetabulum. The anterior extent is about 2 o'clock. So it's not. Here you can see the iliopsoas indentation, the iliopsoas notch. That would be 3 o'clock. So we've not taken the capsule there. You see the capsule is entirely intact anterior to the iliopsoas notch. And as a result, we don't see the iliopsoas at all. And generally, we should not see the iliopsoas. So our capsulotomy then is approximately 12 o'clock to 2 o'clock. We will extend it in more posteriorly in cases where there's more posterior pathology, either on the femoral or the acetabular side. Slingshot with final.
So Ben, what's your plan here for the labrum?
Yeah, so my plan is to repair this labrum. The labrum is destabilized, but the tissue quality, I believe, is very good. So I think we can perform an anatomic repair with the controlled tension anatomic repair technique. This is a knotless technique, which allows us to perform the repair in a very efficient way and preserve the seal of the femoral head of the labrum against the femoral head. So I've gotten somewhat lucky in that I titled the talk or titled the surgery before getting to see what's inside the hip. And I think we've been fortunate in that what is inside the hip is does correspond to the title today.
Ben, I think one of the most useful bits of information I think you gave me in considering capsular preservation is to put away the shaver. And I think what I see you doing here is a technique of elevating the capsule and also placing some traction stitches around it. Have you gone through an evolution in the way you feel about the capsule, how you prepared yourself for later repair? Do you use different techniques in different scenarios to make sure that you're respecting the capsule and its role in stability?
Yeah, absolutely, Brian. Great question. So you're right. What I just did is I placed a traction stitch in the capsule. That's at about the 1 o'clock position. And so instead of shaving capsule to access the capsulolabral junction, we elevate the capsule. And this traction stitch helps quite a bit in that regard. You can flash, Brian Lee, to the outside view for a second here. On the outside view, you can see that I have clamped that suture here to across the skin with a large peon clamp. And you also see that I've now created a distal lateral accessory portal or distal anterolateral accessory portal. These three portals of mine now form roughly an equilateral triangle. And there are a lot of legitimate variations of where to put portals, and there's nothing wrong, I don't think, with any of them. Everyone has their own version of this, but my typical version for a standard knotless labor repair like we'll see today will be this equilateral triangle of three portals. So Brian, to your point, I've not shaved the capsule. I just shaved a tiny bit of the synovium. What we'll do next is use an RF wand, and first we'll just shrink a little bit of the capsule right at the junction. What I want to see next is the superior extent of the labrum. If I try to elevate the capsule from this view, let me show you what will happen. From this view, I put the wand here thinking I'm on the rim, right? But I'm actually not. When I go to the bird's eye view, you can see that I would be amputating some of the labrum. If I push the capsule north, you see there's actually quite a bit more labrum there. And I don't want to amputate that. I want to preserve the entire width of the labrum on the capsular side. In order to do that, I need to carefully expose the labrum and carefully expose the junction between capsule and labrum, so I see the entirety of the labrum. And this is the entire width. You can see that's probably five or 6 millimeters in width from the bird's eye view. And we wouldn't, from this view, you just simply can't see that width from the intra-articular view. So I like to use both the intra-articular view and the bird's eye view for the capsular elevation. And then at a later point, we'll also use the upper deck view where the tip of the scope is inserted into the capsulolabral recess to directly view the interface between the bone and the labrum. So at this point, I'm elevating capsule, working superiorly, working away from the labrum with care to preserve the chondrolabral junction and capsulolabral integrity. So here again, a little bit of shrinkage. Brian, how does that correspond to how you've approached the capsule?
Yeah, I think I've always been a bit circumstantial about how I approach the capsule. Maybe in somebody that does not have a cam lesion as large as this patient, I may consider, a more minor or periportal capsulotomy approach. It might save me a little work at the end in not having to repair a long longitudinal cut or a T-cut. I don't think that I'm necessarily committed to one particular capsule approach, and I try to customize it based on the clinical scenario. But I think this demonstrates very nicely how the capsule can be preserved while still getting good exposure to place your anchor safely. So these are great tips and great pearls that I think help us all learn how to do this better.
Ben, because how about you? How have you approached things?
Yeah, so I mean, traditionally in the UK, most of us who are trained by Villa would actually use the lateral approach. So that allows us, or most of us would probably use 3 or 4 portal techniques. And because of that, our capsulotomies are fairly small anyways. Because we use a separate one, the Dean's portal, for the peripheral compartment. So our interportal capsulotomies are not that big. And secondly, we'll be focusing on periportal capsulotomy. So that's what I'll be doing in my hip scopes.
Yeah, that's great. And as I think we've all mentioned at this point, there are many ways to skin this cat. I think one of the points we've perhaps converged on over the years is that the capsule matters and that we would like to preserve it one way or the other. Everybody agree with that?
Absolutely.
Yeah, I think the point is, if you're making the effort to preserve enough capsule to repair at the end, it can only be a good thing. We've all seen the unfortunate postoperative MRIs with large capsular defects and, iatrogenic instability, and as atraumatic instability is, we've gained more information on what that is and how to diagnose it. I think taking this approach is better overall for everybody. In the case where you have a even larger cam lesion, would you potentially extend your capsulotomy to a T-cut, or through manipulation, are you able to get enough exposure that you can get it all done through this portal to portal capsulotomy?
Yeah, so again, I think there are, like with everything, multiple ways of skinning the cat. The goal being to have great access and visualization of the cam morphology and femoroplasty, and to preserve the capsule while you're doing it. And by the way, what I'm doing right now is I'm burring the edge of the acetabulum and creating a bleeding bed of bone here, to which I will be able to do the repair. There's no particular deformity on the acetabular side that we're treating here, so this isn't much of a rim trimming, rather just a buffing of the rim to create a biologic environment for healing, which we believe to be important. So to your question about the capsule and cams, I do rarely use a T capsulotomy. Most of the time, I'm able to get great access to the cam lesion through just this longitudinal capsulotomy with the assistance of a retraction stitch, and I'll show that when we get to the femoroplasty. But no need to be dogmatic. There's certainly multiple ways of approaching it. How about you guys?
So Ben, going back actually, and I'll come back to what I do for the peripheral compartment, but going back to the labrum,
Yep.
when do you decide to repair as opposed to debride, or is debridement a lost art?
That's a great question. I think it must have been about 2016. We published a paper entitled, "Is There Still a Role for Labral Debridement?" in 2016. So that's maybe about 7 years ago now. And our point was there was still a limited role for selective labral debridement with labral preservation. In the early years of hip arthroscopy, I think there were a number of surgeons, including sometimes myself, who in certain cases resected parts of the labrum. And I would say we almost never do that now unless we're planning on doing a labral reconstruction. But I think there is probably still a limited role for labral debridement, by which I mean a very selective touching up of a minor labral tear, not a resection of the labrum. How about you, Vikas?
So would you be tempted on this patient, because it's not coming off the labrochondral junction completely, well attached, the base is well attached, to do a touching up job and be aggressive on the cam lesion?
So I'm definitely tempted to be aggressive on the cam lesion, because I think that's the what is sort of behind the problem here. In terms of how best to treat the labrum, it's a very good question to ask. And the data that we have has, with whatever data we have comparing labral debridement to labral repairs, has primarily shown that the labral repairs have come out better. But to be fair, some of those cases were more aggressive labral debridements than what we're talking about doing today. So I think it's a question worth asking. Could we get away with just doing a very slight touching up of the labrum on this case? The reason that I decided to do a labral repair is there was a wave sign, there was chondrolabral disruption, the labrum appeared to be hyper mobile along with that wave sign. So I'm hoping to accomplish two things with the labral repair. One is to improve the biological environment of the labrum by bringing neovascularity from the bone and to allow sort of a biological reset for this labrum. And second, and maybe perhaps less important, is to achieve a stabilization from a mechanical standpoint. of the labrum. And by the way, this is the upper deck view that I referenced earlier, where I'm seeing the interface between bone and labrum, so that I ensure I don't leave any beak of bone protruding into the labrum. Those beaks of bone can be actually quite fragile and subject to fracture or microfracture, and hence a source of pain.
Ben, I wonder if for 1 second you could look at the transitional zone. I wanted to make an annotation to try to highlight a question that I was going to ask you.
Sure, absolutely. Let me.
So
I'm
yeah,
here.
so you see,
transitional,
and we're just kind of using
scope ones.
the Proximity software in order to make this annotation. But what I wonder is, I've seen this great algorithm you put together on various techniques and options for labral repair, reconstruction, augmentation. Do you ever try to excavate some of that acetabular rim in order to gain some real estate? If you have a hypoplastic or a small or diminutive labrum, do you ever try to trim back some of that bone in order to use some of that backside articular cartilage to augment your repair, kind of increase the bulk or the volume of the collagen, that you loop your suture in? Or do you, in that case of a hypoplastic labrum, would you go right to an augmentation or even perhaps a reconstruction?
Yeah, so and this is, I think we'd all agree, not a hypoplastic labrum, but if you did have a hypoplastic labrum, I think what you're describing is recessing the acetabular bony rim further so that you can actually roll up the labrum and a little bit of the peripheral cartilage into the labral repair. Is that correct, Brian?
Yep, that's correct.
Is that what you're describing? Yeah, and it's something I certainly have done. Today's demo isn't on labral augmentation or labral reconstruction, but those techniques using the knotless pull-through technique for me have evolved so far that today it's so reproducible and so easy to do a labral augmentation or reconstruction that I think the indications have grown for labral augmentation or reconstruction in the setting of a hypoplastic labrum, and probably the other techniques, their indications have somewhat shrunk. But never say never and never say always. I think what you described certainly can still play a role. True.
Well, Ben, we've got a couple of comments coming in. There's Mark.
Sure.
His student is watching your surgery, and the comment is that how does Ben manage to get some excellent access views to all parts of the joint without actually scuffing the femoral head?
Well, I think Victor Lizzalaturi published on femoral head scuffs, and the conclusions of his paper on that topic were that femoral head scuffs, first of all, are common, or were in his series, and second, at least the small ones from spinal needles and such didn't cause any terrible consequences. So, having said that, we'd all like to avoid any femoral head scuffs, and we take a lot of care to avoid them. So I started with the discussion of the portal placement and the description of how all of my angles, all of my portals, and all of my instruments are aiming in a direction that is away from the femoral head. So that's a really good starting point. Is start with angles where all of your instruments are aiming away from the femoral head. That doesn't entirely protect the femoral head, but it certainly helps. The second thing is to have an acute awareness of the danger of the scope itself. I think the scope itself is probably one of the most common culprits for scuffs of the femoral head.
Or the other answer may be that he's hiding his scuffs well in this operation.
Yes, that's the 400 level surgical technique. Absolutely.
Ben,
actually, right now, the great Dr. Ben Coons is holding the scope, so he's not trained yet in hiding the scuffs.
Then
Dr. Coons is assisting me here. He's our fellow here at American Hip Institute. I'd like to take a second to thank him for the help with this procedure as well. And just to show what I'm doing right now. So we're placing the anchor. Hold there a second. This is a all suture knotless anchor. And this patient, not surprisingly, has quite hard bone. And sometimes the anchors actually don't deploy easily when the bone is very hard, because the walls of the drill hole are very smooth, and the all suture anchors need something to catch on. Anyway, we deploy the anchor, we pull on it to test it, and then what I'm doing here is I'll take the Scorpion. I've passed the anchor through the Dalla portal. Hold the scope a second. And then I've pulled the shuttle sutures out of the mid-anterior portal. And now we're going to pass the repair suture around the labrum using a labral Scorpion. So this labral Scorpion comes into the joint. I want to see where it's biting, and I want to see that I'm not penetrating my own sutures, and see that I'm right next to the bone here at the junction between the labrum and bone, and then look at the articular side and see that I'm coming through the chondrolabral junction like so. Suture retriever.
Ben, I wonder.
Yep, go ahead. Suture
I wonder, you've been an early adopter of a labral base fixation, published a lot on that,
Yes,
versus looped repair, knotted techniques, and now onto knotless tensionable devices. Could you walk us through that personal evolution a little bit for yourself, and kind of where you've come from and where you're at now?
Yeah, absolutely. Hold the scope a sec, then. So labral base refixation was a technique that I had first published on and described in the early 2010s. And the purpose that labral reconstruction served was to provide for an anatomic repair of the labrum and to preserve the labral seal against the femoral head in an era where most of the time we were doing a labral takedown. We were actually separating the labrum from the adjacent cartilage and then refixating it afterward. So in that era, the other techniques often produced a labrum that was everted or pulled away from the femoral head. So a big part of our research, hold there, and both the initial description and the subsequent publications that we put out on the labral base refixation were intended to solve that problem in that era. So labral base refixation was something that I personally probably became somewhat associated with. And then we had improvements in the technique where we were able to do labral repairs without labral takedown, with preservation of the chondrolabral junction, as we're doing here. We also had improvements of the technology with anchors like we're using here, which are knotless and tensionable, where we can control the tension, and that led to the birth of the controlled tension anatomic technique, which is what we're performing here today. The goal remains the same. The goal is to preserve the anatomic labral positioning and the seal of the labrum against the femoral head. How about you, Brian? Is your evolution?
I think intellectually preserving a triangular shaped labrum has obvious benefits. I think visually it looks really nice. I think you and others have shown that a looped repair versus a base fixation may not matter biomechanically or clinically. And unfortunately, I think as you see more revisions, you start to see some things that made sense early on not work out. I've seen some of the base fixation cut through the base of the labrum and kind of losing the integrity of the transitional zone. And I've heard others talk about the labrum as sort of a giant marshmallow that, really within the substance there can be a fair amount of degenerative tissue. And so since I've switched over to almost nearly always a looped repair, I've been happy with that. I also used to be a, partial believer in not abrasion or not impingement.
Sure.
Maybe it was a construct of industry trying to sell more implants, but then gradually I started to see the true, the actual iatrogenic damage from knots. It can create granulomas, it can irritate the capsule and create scarring around it. I've seen the knots migrate and abrade the femoral head, and since I've switched over to all knotless, I've not seen that phenomenon anymore. And so I think that's an example of the evolution of some of these concepts with technology. And I think we're really at a good place now with what we're able to do, and do it in a very atraumatic way. Definitely.
I want to just talk a little about the labral repair technique, because we're going to blink and it'll be over. So we're placing these anchors at intervals of about 6 to 8 millimeters apart. And again, these are all suture anchors that we're placing. We test the anchor and pull on it, make sure it's well seated. We'll then use a suture retriever to pull the white sutures, which are the shuttle sutures, out the mid-anterior portal, hold the scope in. We'll then use the scorpion and pass the suture from the capsular side to the articular side through the area of the chondrolabral junction, suture retriever. And then we retrieve the end of the shuttle, which has the loop on it, which is the round end of the white suture, the shuttle. Dr. Coons is loading the repair stitch through the looped end of the shuttle there, and hold the scope in. And then I'm pulling the shuttle through. That pulls the repair stitch back through the anchor. And now this is a one-way catch. So I pull it to the desired tension. This is the controlled tension anatomic portion. I know where I want it to be in terms of tension so that it will still seal against the femoral head. And it is possible to over tension the labrum so that it doesn't seal against the femoral head or is everted. And one of the advantages of this technique is that we're able to control that quite well. So we'll go on to our fourth anchor here. Hold there. And
what's the thought process behind the 6 to 8 millimeter gap between anchors?
Yeah, so we've done some mathematical modeling of the distance between anchor placement, and I think it's obvious to everyone who's watching that the closer the anchors are, the more stable, the more stability there is to the intervening sections, and the further apart they are, the more potential wiggle or movement there can be between the anchors. So past about 6 to 8 millimeters, that mobility of the intervening segment increases not linearly but exponentially, and so we've sort of married the math with what we see physically in the scopes, and marrying those two things together, that's sort of been the sweet spot. I don't have an objection to more dense anchors. Hold the scope again. And on the other end of it, there's certainly probably cases where you can get away with using fewer anchors. So I guess we all use our own theoretical analyses to come to our practices, and then we test our practices by following our outcomes. And if our outcomes are good, then we say our practices are working. So that's more or less how we've approached it here.
So as an educational measure, would it be safe to say for the audience that anchors a centimeter apart are safe? Or would you go below?
Your question is it enough to place anchors every centimeter?
Correct.
Side cutter. I think in a lot of cases it probably is. And again, we don't know perfectly. Hold there. But in a lot of cases, I think it probably is. Alligator Gossamer.
Brian, what about you? How far are you placing them?
I'd say that's equidistant, similar to the way Ben is placing them right now. And one of the other observations I'd make is
Real.
I've often wondered if the wave sign or delamination also benefits from reapproximation of labrum to bone, almost like tent staking the articular cartilage to take some of the tension off of it. There was an era, I think, where people used to commonly elevate the labrum away from bone along with that sheet of articular cartilage, put fibrin glue behind it, do some things to try to get that calcified cartilage base to stick again. And I guess maybe I'd ask you, Vikas, if you have any experience with that yourself, or if you think that a looped anchor repair like this is enough to restore stability to that articular cartilage, as long as the cam lesion is being addressed at the same time.
I mean, you're absolutely right. And that's why I asked the question to Ben in the beginning, that is there a temptation to leave this labrum alone and be aggressive on the cam side? Because if you look at the 10-year data, both from states and also from the UK, and our registry work in terms of comparison of labral treatment with repair, the results are pretty similar in terms of the prompts, both at the 10 years and also early outcomes for IHOT 12s. So are we actually if we treat the problem well, i.e. the cam lesion, does the chondrolabral junction repair not matter if you tidy it up? And the honest answer is, I don't know. So we are obviously aggressive. We do labral repairs, but for me, it's a centimeter apart. And we went through a phase where we were using fibrin glue behind the lesion, injecting it, and also doing a microfracture. Published a series, Willers published a series on that. But again, short-term outcomes. Yeah, go ahead.
Oh, I was just going to say, one of the wonderful things about ISHA is that it is an international society, and there we all wind up getting a little bit enclosed in our own bubbles in our respective countries, and there are real differences between the countries in terms of tendencies. Alligator grasper. Actually, I'll take that. So, for example, I think in the U.S. there's definitely a very big movement in the hip arthroscopy world toward labral repair, and also probably a fairly substantive movement toward labral reconstruction in cases of questionable integrity of the labrum. And we may be forgetting about the role for a labral debridement to an extent, and in another country that may be used more commonly. So one of the great things about this society is that we get to have these conversations and cross-pollinate across countries. So I really enjoy that.
So Ben, quite a few questions coming in actually, because we've got over 100 people watching live. No pressure, absolutely, from all around the world. And you're doing a great job, Ben. So fantastic labral repair out there. A few questions. Do you use the radiographs for each anchor always?
Can you spotlight the fluoro screen for a second? Brian Lee, can you spotlight the fluoro screen for a second, please?
Alexandros Travaris from Greece asking that question.
Yeah, so I'm just spotlighting the fluoro screen here. I used the fluoro in this case for the most lateral of the anchors. And that's helpful in the AP fluoro position, in that I can clearly see there that the drill is headed away from the joint and is not going to penetrate into the joint. It is possible to move the fluoro into various positions to get a similar view for all of the anchors. However, it's a little bit time consuming. So I don't typically use the fluoro for most of the anchors. Instead, what I do is I see the placement of the anchor on the rim with the upper deck view, and then I switch to an intra-articular view and watch the articular cartilage to make sure that there's no movement of the articular cartilage and the drill is not therefore approaching proximity to the articular cartilage. So I did just want to if you could switch back, Brian Lee, to the intra-articular view, please. I did just want to wrap up the labral repair. I think our title here was efficient anatomic knotless labral repair. So in terms of efficiency, if I am right, I think that took about 12 minutes to do a 5 anchor labral repair. So we can, that's about as efficient as I've ever been in the course of my evolution in hip arthroscopy, and I'm happy with that. Maybe we can shave a couple minutes off in future years as we continue to improve technology and technique. But certainly 12 minutes is something I think we can all feel pretty good about today for a 5 anchor labral repair. And I owe a lot of thanks to the technology as well as the technique for how that's evolved. Here we can see the completed repair, and we can see it from an intra-articular view and from an extra-articular or bird's eye view. Hit lavage, please, Joe. And what I would like. Sorry, go ahead.
I was going to say, sorry, that's a gorgeous repair, and I think it's important. I'm circling your hands down here, and there was a question about the use of cannulas. I noticed that you tend to use slotted or open-ended cannulas, and maybe have you used cannulas in the past, and how did you come to a preference using an open cannula system? Is it speed and efficiency? Is it just personal preference? How do you decide?
Yeah, so I do use cannulas for the repair portion. Most of the rest of the procedure, I'm not using cannulas. The 2 steps where I use them are for the repair and for the capsular closure or capsular plication. And the reason that I use cannulas in those steps is twofold. Number one, for avoidance of tissue bridges, and number 2, for suture management. And I guess perhaps there's a third, which is management of the fluids, but that's probably the least important in these cases. So I do like to use the cannulas labral repair and for the capsular closure, which we'll show here in a little bit. And at this point, we'll take traction off of the hip. Corbin, you can take off traction. And we're going to get what I like to call the money shot, which is where we see the seal of the labrum against the femoral head. So just pause there, just half flexion for a second. Just like that is fine. So at this point, we can see the labrum sealing against the femoral head. We see the contact between the two. And this is what I was referring to earlier when we started the evolution of labral base refixation in response to cases where when you got this money shot, you would see gap formation between the labrum and the femoral head. We don't want to see gaps between the labrum and the femoral head, because if the labrum is not touching the femoral head, then it cannot serve its duty of providing a seal. So I'm very happy with the money shot here in that we've reproduced that seal throughout, and we've got good security and good strength of fixation, but at the same time, we've not overly everted the labrum away from the femoral head. So that's all good news. And next, go ahead.
Stay on that shot. Couple of questions there. One is from Tim from the UK. How far from the rim is it okay to put the anchor? How far do you?
So the closer you are to the rim, the easier it is to maintain the anatomic position of the labrum. So with the use of the Dalla portal and the angles that we have angling away from the joint, we're able to place the anchor almost right on the edge of the rim where it interfaces with the labrum. But the prep work was important in getting to that point, because we're able to create a flat surface of rim using the upper deck view, where we see that in that junction between labrum and femoral head, between that labrum and acetabular rim, and we can create a landing point for the anchor that is right adjacent to the labrum. But the other part of the question, with a fiber, please. The other part of the question is, what if you're a little bit further away? If you're further away and you're using technology like this with controlled tension, then you can still be okay, because you can control the tension and thereby avoid overly everting the labrum away from the femoral head.
Cool.
So next phase, we're going on to the femoroplasty, and so we're placing a traction stitch here in the capsule. Go to the outside view for a second here. Spotlight, Brian, the outside view. We'll just see here we go. So I have now a traction stitch placed in the Dalla portal. This is on the femoral side of the capsule. And spotlight back to the intra-articular view, please. Okay, so now here you can see that traction stitch, and you can see how much mobility it creates of the capsule, where we can really get quite a big view. So Ben, if you could hold that, and just, you got my glove there. Yep, and right there. If you could please airplane the table away from me. Thank you. And so this here is the peripheral compartment. We're going to get a nice wide view, and we're going to remove the periosteum from the femoral neck here. We can take an X-ray while we're going. Yeah, X-ray. Yep, find us there. And Joe, turn the alpha angle on the hip check there. Yep. No.
Ben, the ever important question: how much, how far, and how deep?
Yeah. So, we're generally aiming for an alpha angle in the low 40s, so that's the how much. And in terms of the contour, we've placed a lot of emphasis here on a spherical contour of the femoral head, and I think this has been taught a lot of different ways. People have taught doing it with fluoro, without fluoro. People have taught to create slopes or various shapes. Some have thought of it as removal of a bump. We've thought of it as sculpting a sphere. And while it could be argued that not every femoral head is spherical as made by the man upstairs, if we're going to interfere with the man upstairs work, then I think the best thing we know to aim for is a perfect sphere. X-ray there. So
man or woman, Ben.
What's that?
I said man or woman upstairs.
Yeah. You know what, because you know what's the difference between God and a surgeon?
Go ahead, Ben, enlighten us.
God does not think he's a surgeon.
Okay, on that side, on a lighter note, there's Emily Becker who's congratulating you as well, that Dr. Ben is the only surgeon I've worked with who can make a labral repair look like a reconstruction due to his technique. It's honestly incredible. There you go.
Oh, that's very nice. Thank you so much. I really appreciate it.
Ben, I noticed that you're using some templating software, which is proprietary. Have again, as these technologies become available, how do you decide when and how to adopt these technologies as something that enhances or improves your practice, or something that can enhance your patient's outcomes, or something you pass on?
Yeah, I wanted to just spotlight this for a second, just to show that I'm measuring the alpha angle here before I get started on the femoroplasty. The alpha angle here is 69 degrees. I think you can see that on the screen. We'll aim for a final alpha angle somewhere in the low 40s. And as far as your question about when to adopt technology, I've found this. I had done an awful lot of femoroplasties before some of these technologies came about, so I don't think they really changed my technique very much at that point. However, very useful as a teaching tool, and I think they've been helpful for our fellows to track what it is that I'm doing, and then to replicate it. And also, I think during the learning curve for fellows during fellowship or afterward, it it's helpful just to make sure you didn't miss anything and make sure you go through a systematic checklist. Many of us have read the checklist manifesto and believe in the concept of having checklists, and going through a checklist of the views you're going to get and making sure you have the contour you want in every view is a useful exercise. Brian Lee, you can go back to the intra-articular view. Burr, please. So just to talk about the view we get, Brian, you were asking earlier about the capsulotomy and do we do a T capsulotomy and stuff. So we're seeing a pretty darn broad view here. Lavage, please,
It's a great view.
of the femoral neck. And we can go here all the way to the medial synovial fold here and beyond. So just to see how far we can see just about 360 degrees of the femoral neck. That's the medial synovial fold. And then let the knee out a little bit, Ben. And we can also go out laterally and get to the lateral retinaculum there. We'll do that more in extension as well, but even in this position, you can see the lateral retinaculum right there. So let's come back to our femoplasty, and we're pulling tension on the suture, Ben. Okay.
What position is the leg in at the moment?
I'm sorry, can you repeat that?
I said, what position is the leg in at the moment?
You say?
What
Position of the leg. Oh, it's at about 45 degrees of flexion and neutral rotation right now. If you can see the outside view, I have the C-arm canted back, thanks to Gene here, about 30 degrees. And this is giving us a view that essentially replicates the Domb view. So this will be at about 2 o'clock on the femoral neck, which in this case is probably the epicenter of the cam deformity. So I find it helpful to start at 2 o'clock because it is probably the most common epicenter of cam deformities. And then we'll work at 2 o'clock, and you'll see in subsequent fluoro views, we'll do 2 o'clock, 3 o'clock, 4 o'clock, and then we'll go to 1 o'clock, 12 o'clock, 11 o'clock. So throughout the procedure, I'm going to get fluoro views as we go. X-ray. So we're working our way proximally into that deformity here. X-ray. There you see the Burr X-ray on the deformity, but we still have a ways to go. An interesting thing to talk about is when we're doing a femoroplasty, up here looks like kind of healthy cartilage. But if I stop there, X-ray, so with my burr on the edge of the cartilage, I will not be proximal enough. Go to the spotlight the fluoro view for a second, or the small screen. Yeah. So you can see where my burr is. It is distal to what will be the alpha point. So I need to go more proximal than that. And to do that, I need to remove what looks like not that bad cartilage on the femoral head. So I think this is a point of some conversation. And I know that there are different feelings on this question in the field. As some might feel that it is not worth taking what looks like good cartilage to make a sphere. And then some would be in the camp of we need to achieve a sphere at all costs because the asphericity is what started this problem in the first place. We tend to be a little more in the second camp in that discussion. A little more flexion, Corbin.
Ben, when you're customizing your bony decompression on the femoral side, are you considering the participation in the sport of a particular athlete? If you have a hockey goalie and the functional demands of butterfly positioning versus Irish dance and high leg kicks, are there ways that you're customizing sport specific patient specific bone recontouring when you're planning and performing this?
Definitely, it's a great question. And somebody doing high kicks, a cheerleader, or a dancer, or a gymnast, they've got really different demands than a hockey player. The hockey players have a lot of flexion and internal rotation. in the skating motion. Basketball players, that's another thing altogether, because there's so much lateral movement that they have a lot of flexion and abduction in basketball. And football is kind of a combination of the two. There's a lot of lateral motion, but there's also a lot of squatting and getting low, depending on the position of the football player. So I think it's very important to consider the sport. Having said that, I'm still aiming for spherical. The question is, how far am I going to take that spherical contour? And in this case, we have to consider that he needs a lot of flexion and internal rotation. And we also probably should consider that he has a relative lack of anaversion. So his anaversion was 1 degree. And as Vikas pointed out earlier, we're not doing a femoral osteotomy here. So our treatment for his impingement, including the retroversion, is the femoroplasty X-ray. So you can see on the X-ray, we're approaching where we want to be. We're still not there, but we're certainly getting closer. And
so Ben, isn't it
yep.
counterintuitive that on the one hand, you're trying to create a good labral seal with a labral repair, and
yep.
then you take a large chunk of bone away from there as high as possible, and as soon as you've got flexion, there is no labral seal.
Yeah, that's an excellent point, because some of the other techniques that have been described for femoroplasty create a concavity in the femoral neck, and when you flex the hip, that concavity enters the joint and is out of contact with the labrum. So we put all that work into getting a great labral repair, only to disrupt the contact between the labrum and the femoral neck with femoroplasty. That makes no sense. X-ray, and that's exactly why we've espoused the importance of a spherical contour. So if we do keep the contour exactly spherical, then we should be able to maintain contact with this area that I'm working on right now. And we'll evaluate that afterward and see that that contact remains with the area that we're making spherical here. X-ray. So here we're approaching a pretty good point. The alpha angle is now 45 degrees. I'll probably take it a little bit further in some of the other positions, but you can spotlight the fluoro there for a second. So you can see where we are so far. We'll go a few degrees lower, but we'll stop at 2 o'clock. We'll move to the next position, which will be 3 o'clock. Let's go to second position, Corbin, please. So we're going to flex the hip more. We'll flex it to about 60, 70 degrees now, and X-ray there. Okay, just a little distal, Gene. X-ray again. Okay, good. So here we're in a pretty good spot, and let's go to let the knee out a little bit. So we externally rotate X-ray. And now we can see 4 o'clock. Let's externally rotate a little more, even X-ray. Okay, 4 o'clock there. So we've achieved good sphericity, spherical contour at 2 o'clock, 3 o'clock, and 4 o'clock. Let's now go to extension, 10 degrees of C. So now we're going to go to 1 o'clock. We'll come into extension with the leg. The C arm is going to come to 10 degrees of C. And this is going to be our 1 o'clock visualization. And throughout this, we're visualizing the same area arthroscopically and fluoroscopically at the same time, X-ray. That's very important because if we are seeing one part arthroscopically and a different part fluoroscopically, we're not going to have a good understanding of what we're working on. So here on this view at 1 o'clock, you can see that I'm not done, right? There's still more aspherical shape to resect here. X-ray, I'll put my burr on the edge of it. That point there that I have my burr on is a prominence, and this point here, X-ray, that I have my burr on now, that maybe not quite that much X-ray there. That's about where I would draw the alpha point. So I have to come more proximally than I am. I'm working here. I'm starting to work above the lateral retinacular vessels with care that I'm not going to disrupt the lateral retinaculum. Hit lavage, please.
So Ben, going back to the preoperative CT plan,
Yep.
if I remember correctly, it was mainly anterolateral and distal, but you're obviously being a bit more aggressive, and you're going lots more medial, and you're going a lot more proximal as well. What's your theory behind that? Are you ignoring that plan, or you just want to get a sphere?
I'm not using the CT scan. That CT scan has an automated reading system on it. That's a software kit. I'm not depending on that to tell me the entirety of the deformity. I'm going to use intrapleural throughout and verify sphericity. What I am not using is the arthroscopic view to tell me what's out of round, because very candidly, if I look at this arthroscopic view, I can't tell if we're spherical or if we're not, because I'm not seeing the entirety of the globe. So the fluoro view gives me a view of the entirety of the globe, where I can tell that. Again, those automated softwares, they're a good start, and they'll pick up the epicenter of the deformity, but you can see fairly clearly on the last fluoro shot that I took that there's still an area of asphericity there. That's at 1 o'clock. I think that actually is probably still in the part that was being picked up though on the software. My kind of read of what was being picked up on the CT scan was that the epicenter was 2 o'clock, but it extended probably from 1 to 3. So in any case, I think it gives you a good starting point, and then I would not want to be doing a femoroplasty without fluoroscopy because I would be lost. X-ray.
Ben, it's amazing that you've been able to accomplish so much in such an efficient amount of time, and it's looking amazing right now. I wonder, in your own evolution from posted to postless traction, have you found any changes in your ability to perform femoroplasty, or subtle changes and nuances of leg positioning, or differences, either more challenging or easier with that evolution to postless?
I think it's mostly easier because we don't have a post getting in the way of the motion. X-ray. I don't see any ways that it's made my life harder. How about you?
I'd say the only thing it has probably done is it can change portal position. That thigh compression from the post can create a little distortion in the tissue planes, the portal tracks, and the portal location in some cases. But otherwise, I think early on, some people would say that that postless would permit better adduction, internal rotation, and some of that dynamic movement of the hip at the time of mapping or execution of the femoroplasty. But I haven't found it to really change things much for me.
Yeah. Okay. This is the 11 o'clock view, because, and to your point, there's nothing to do here. This is already round, so I don't need to. There's no deformity here. I don't need to do any resection at 11 o'clock. Same thing was true at 12 o'clock. So it was really primarily 1 to 3. Go back to neutral for a second, where the majority of our work was. Gene, see back 30 again.
Yeah, whilst you're on the lateral side, there's a question from Scott Rosenfeld. If you could actually show us where you think the retinacular vessels are. Wait 1 second. Yep. To show us where the vessels are. Yep. Yeah. Sure. So here are the ease up on the tension a second, Ben. So here are the vessels here. And that's the entirety of the lateral retinaculum. And again, you can drive around pretty far here, posterolaterally, and see so we're even past the vessels there posteriorly. Let's go back to flexion now, please. And so back into flexion, back to the original position here. Go right there. X-ray. Good. Can you spotlight that screen there for a second? So
as I referenced earlier, not trusting entirely technology of any sort. I'm using the technology to demonstrate, but I'm also using my eyes on the fluoro screen that doesn't have this angle measured to see that I've achieved a spherical contour. The measurements are reading out now at 41 degrees. This is at the 2 o'clock position. So this is kind of where we wanted to be, basically. And at this point, we're going to do the last step, which is a capsular closure. We talked quite a bit earlier about the importance of preservation of the capsule. If you can take that out, if we're going to be able to repair the capsule at the end. So we preserve the capsule by a careful capsulotomy, by use of traction stitches. And at the conclusion here, we should have good capsule to preserve. Brian, you were talking a little bit about the individual sports. One of the interesting things that I see in hockey players, and I'm sure you see a lot of as well, is this phenomenon where they have cam morphology that looks like dramatic impingement, but they actually have relative dysplasia of the acetabulum, 2 switching sticks. And I think that's a developmental thing as well from the skating, or worst of all, in the hockey goalies. But I tend to think that those are not really instability cases. What's your take on those?
Yeah, I'd say, all dysplasia is not created equal, and a lot depends on the dynamic force coupling and the periarticular soft tissue envelope to me. So if you have an 18-year-old lateral center edge angle 15, acetabular index 15, hockey goalie with a large cam morphology, that hip may be structurally quite stable. If you have somebody with a loss of the force coupling, a higher lateral center edge angle and a more favorable acetabular index may actually be a more unstable hip functionally. So I definitely don't lean on those numbers in particular. I do think about those, the functional demands and the sport specific conditions. And I agree with you. I think that tends to be a more stable hip.
And because I think hockey is probably a little less popular in the UK from what I know, but what are some of the sports specific things you see that we may not?
Yeah, I mean, for us, it's mainly rugby and football, right? And in terms of morphology, I think I'd quite agree with Brian on that approach, because we do see that as well a fair bit in rugby. But again, it's not necessarily the dysplasia. It's probably the cam which is actually causing the issue in specific moments. So I'd agree with that thought process.
This is the rectus femoris right there. Tendon. You can see we've preserved the entirety of the rectus femoris by placing the portals sufficiently laterally. We never touched it. We've preserved the whole capsule here. That's the acetabular side. That's the femoral side. And I'll take the vicryl stitches now. We've used vicryl stitches, which are absorbable stitches. By the way, here's one last look at the femoral head, the femoroplasty, and the labral seal. And we'll now place sutures to close the capsule. And we are, in this case, not aiming for any kind of application. This is going to be a side-to-side closure. If we were aiming for application in a case of instability, we would place these sutures with bigger bites and with an obliquity that would lead to a shift, a capsular shift of the inferior of the femoral side of the capsule, shifting it superiorly. So we'll place all of the sutures. Yep. Go ahead.
It almost seems that there may be a secondary advantage of the capsule repair. You showed before you kind of lift the capsule up. I wonder if you did not repair it, would those capsular leaflets kind of sink down and maybe stick to the labrum, and maybe that's the cause of some of the adhesions that form, and by virtue of reapproximating those capsular leaflets, you're actually kind of moving them away from the biology of your repair as well.
Brian, that's a fantastic point. And I think there are probably some things that we all do that we're not aware we're doing that are helping our outcomes. And you may have just pointed out one for me. We have not seen a lot of capsulolabral adhesions, something we rarely see. And maybe from a technique standpoint, that's one of the reasons why.
I think this may be a question of the viewers as well, but we're seeing you pass a number of sutures and
Yep.
really meticulously retrieve them in a highly organized way. And I'm sure through all the labor reconstruction work you've done, you're becoming very facile at suture management and organization. But was there a point that you would pass and repair, or have you always done it this way, where you're passing multiple sutures and then repairing at the end?
Well, if there was a point where I tied knots as I went, it didn't last very long, because what I found almost immediately was that it closes down the view, and I become unable to place as many sutures as I would like in the orientation I would like. So I've found it a huge advantage to place all of the sutures first and then tie them subsequently. I'll show the outside view in a second. It's actually not me who's good at suture management. It's the great Dr. Coons here, who is helping me. So maybe we could spotlight that outside view for a second.
Ben, what position is the limb in at the moment? Are you closing this in flexion or?
Yeah.
Yeah.
Yeah, good question. So I'm closing it at 45 degrees of flexion. And I imagine your next question is how do we make sure that's not going to cause a flexion contracture? So the answer is if we haven't removed any of the capsule with the shaver or any other instrument, and if we repair it in a side-to-side fashion, then it shouldn't change the tension of the capsule at all, no matter what position we close in. So it basically shouldn't matter. And I find it a little easier to close it in flexion. Having said that, afterward, I'm going to come into extension and make sure that we haven't over-tensioned it, make sure none of the knots pop or anything like that. So now you can see that we've completed 4 stitches. Dr. Coons here has anchored all of them, or has clamped all of them in order, so we know which is which. You can see it on an outside view. Yeah, good one. Go back. You're back to the inside view now. So back to the inside view, we can see all 4 of the sutures. And just for efficiency sake, I'll show you a quick little trick, which we called the X grab, which is where we grab the sutures in an X formation like this with the suture retriever. So you can see how they're crisscrossed. When I retrieve the sutures in this fashion, then I know exactly which one is which. I know the acetabular side is on my left, the femoral side is on my right, and there's no twisting or tangling, so I don't have to look in the cannula or anything like that. Hold there.
It's amazing
now,
that with this approach, you're really not adding a lot of time, operative time to your case. This isn't the older days where capsular management would take an additional, hour. It's wonderful to see that you're able to restore the capsular stability in a really efficient way.
Thanks, Brian. Yeah, I think again, we've all worked together, and you've done a lot of great things on this in helping develop some of these techniques. And this has been an evolution where we've all learned from each other over a lot of years that I know I've really enjoyed.
There's a question from the audience about rehabilitation protocols. Would you say there's any adjustment or change in your rehab protocol based on the extent of cam decompression, or whether a capsular closure imbrication is done in your hands?
Not really. We've some years back, I learned about the concept of minimizing clinical variation. And the concept is that the more different protocols you have, the more errors are liable to occur by physical therapists or by staff or what have you. So if we can minimize clinical variation, then we actually cut out a lot of those errors. So we used to have 4 or 5 different rehab tracks, depending on what was done. And we actually really cut that back to where we only have 2 rehab tracks. And the only difference between the 2 is the period of time on crutches. Track 1 is 2 weeks on crutches. Track 2 is 6 weeks on crutches. And other than that, most everything else is the same. And that really has helped with the communication with physical therapists, especially when we have patients from a wide geography and a wide range of different physical therapists in different parts of the states and the country.
Ben, any biologics that you actually insert into the hip prior to closure?
Not in this case. I think there's a lot of opportunity for us to develop together in terms of the use of biologics. We did do a study a while back where we looked at PRP injections at the conclusion of the procedure. And the short story was we weren't able to show that they made a difference. And we hypothesized that is because this is not a watertight closure. And a lot of the PRP probably leaked out when we place it at time zero. So now what we're studying currently is the use of post-operative PRP. And we'll start that 2 weeks post-operatively and do a series of 3 of them once a week for 3 weeks. So we're studying the effectiveness of that protocol with the thought that 2 weeks later it is healed enough that it's a fairly contained space and we can put PRP into the joint and expect it to stay there. How about you guys?
So no biologics per se at the moment in terms of PRP or anything, but viscosupplementation, yes. So I do use, especially for those patients who've got articular cartilage being affected, I'll use viscosupplementation.
It's interesting. It's one of the topics that we put some time into research. It, ultimately the outcomes may not be much different 6 months later, but from what we looked at, the use of PRP can decrease thigh circumference early on, so it may have a role in hemostasis. And some of the earlier metrics in pain actually improve after the use of PRP as well. So I think there's definitely a role for it. And that's a great closure. It looks circumferential and complete, and that's amazing that it's almost as though this live surgery was orchestrated for the 90-minute slot, because we're literally right there.
Our timing has been good. I'm going to do a last thing, which is bring it to extension now to just finish answering Vikas' earlier question. So as we bring it to extension, if we see that the sutures pull apart or the capsule pulls apart, then we know we've overtensioned it. And obviously that has not happened. It's held well. We don't see any significant strain on the sutures. So that's a good way to tell that we've not overtensioned it. So if you could now spotlight the outside view.
That looks brilliant, Ben. We're coming up to almost closure. And
do you want to go to that last slide where we talk about the webinars and such?
Before we jump into that, Ben, if you could give us 3 top tips for labral repair for the audience, and 3 top tips for cam resection, and 3 top tips for capsular closure.
Sure. So labral repair, cam resection, capsular closure. So for labral repair, a meticulous bony preparation, a positioning of the anchors close to the labrum using the upper deck view, and then controlled tension anatomic technique to position the labrum in an anatomic position where it will seal against the femoral head. For the femoroplasty, number 1, we have to have visualization. So use of traction stitches and whatever modality of capsulotomy you're using, you have to have visualization. Number 2, we need simultaneous fluoroscopic visualization of the same spot that we're visualizing arthroscopically at the same time. So we see the area we're working on both arthroscopically and fluoroscopically simultaneously. Number 3, avoid over resections. Over resections are probably a worse problem than under resections in femoroplasties. As Vikas very astutely pointed out earlier, an over resection will disrupt the contact between the labrum and the femoral head, rendering the labrum you've worked so hard to repair essentially functionless. So avoid over resection, aim for a spherical resection.
And capsular closure?
Oh, capsular closure, topic 3. Number 1, preserve the capsule. If we shave it out, then we can't repair it. So use traction stitches and avoid using a shaver on the capsule during the procedure. For our technique involves I'll say number 2, our technique involves a longitudinal interportal capsulotomy. I'm aware there are other techniques that are perfectly viable that work well in other surgeons' hands, but use a technique that's going to allow you to have visualization without shaving out the capsule. That's number 2. And then number 3 is titrate your repair versus plication. This is not a case of instability, so we did a side-to-side repair, but in a case of instability where you have a younger female with generalized ligamentous laxity, or you have a patient with borderline dysplasia, we may want to tighten the capsule, and that can be helpful to solve their instability by using larger bite sizes and obliquity on the sutures so that they achieve an inferior shift.
That's brilliant, Ben. On behalf of Isha, we'd like to thank you. Phenomenal demonstration of surgical technique for the standard cases that we actually get to do for hip arthroscopy for all the 100 participants around the world. And I'm sure lots of them will be watching it later as well. So big thank you, Ben, to you and your theater team. A big thank you to Proximy for allowing us to use technology for this broadcast, to Caroline and all the tech behind the scenes. Over to you, Brian, to close, and then to Ben to tell us about the next webinars as well.
Yeah, thank you, Vikas, and Ben. A stellar job as always. We learned so much from you, and we appreciate you really pushing the frontiers technically of what we're able to do. And I think this just highlights the value of these live surgeries and the educational platform that Isha has supported, and we very much appreciate the endless support of Proximy and Caroline and everyone involved in orchestrating these. It's an incredible amount of work to focus on performing elegant surgery and also talking at the same time and educating us all. So really a great deal of appreciation to you as well, Ben.
Well, thanks very much to both the moderators, Dr. Kenduja, Dr. Giordano. These are both geniuses of hip surgery who I've learned a lot from over the years. And appreciate having you moderate during this procedure. So to conclude, just a reminder about the upcoming educational program for Isha for the coming year. We will have a series of live surgical procedures that are streamed like this from various centers around the world. Those can be found on the Isha website. And I'd encourage everybody to join them. It's really helpful for us to see how others are operating in various parts of the world. And Brian Giordano will also be leading the organization of the webinar series in which he'll gather expert faculty from around the world for each of the webinars on a different topic each time. So with that, we'll conclude. And for those of you who will be in Cape Town, I hope it will be many of you for the Isha annual meeting next week. And I look forward to seeing you all there. Take care till then.